sure it's an amazing experience, right? To carry a baby and, help couples.
All right, I'm gonna go ahead and admit the few people that are in the waiting room and we can kind of get started.
Cool. I'm gonna disappear. Good luck, guys.
Thank you.
Alan. Thank
Thanks,
you.
Alan.
All right, so we can go ahead and get started. My name is CJ. I'm the physician liaison with Advanced Fertility Center. Happy Pride Month to everybody that's just joined us. So we can go ahead and get started. I will introduce Dr. Mohamad Irani. He's with us at Advanced Fertility Center. You can say hi.
Thank you, CJ. Thank you for the introduction. Good evening, everyone. I am Dr. Mohamad Irani. I am a reproductive endocrinology and infertility specialist at the Advanced Fertility Center of Chicago. It's a pleasure to have Staci today with us. She's the owner and CEO of Family Source Consultants, and Roxanne, who is a case manager at the FSC, and she's also she was a gestational carrier in the past. So thank you all for joining us today. Today's webinar, as CJ mentioned, it's Pathway to Parenthood for LGBTQ+. It's a special day, it's special month. June is a LGBTQ+ Pride Month. We have been helping gay, lesbian, and transgender individuals and couples to have their kids and build their families for several years. So we want this webinar to be interactive, so feel free to use the chat box to submit questions. We'll be happy to answer them for sure today before we finish the webinar. Just to give you some background, we will be starting by talking about gay couples and individuals and their pathway to parenthood. Then we will talk about lesbian couples and individuals and transgender couples. So I would like to introduce first, before we start, Staci, who's the CEO and owner of Family Source Consultant. Thank you for joining us, Staci.
Thank you. I'm so happy to be here. This is one of this month is always celebrated. We've been celebrating this month for many, many years. So over half of our intended parents come to us are same-sex couples. So it's just incredible, and we're really honored to be a part of the building those families. So it's amazing.
Absolutely. And Roxanne, who's a case manager at FSC too. Welcome.
I'm so excited to be here. I love Pride Month. Work with a lot of same-sex couples, and it's very close to my heart. So I'm thrilled to be part of the webinar today. Thank you.
Thank you all for joining us. So to simply, to simplify basically the pathway to parenthood for gay couples and individuals, it's always good to remember that we need the three following factors for any pregnancy. First is sperm, second is egg, and third is the uterus or gestational carrier. So in terms of sperm, it's very important to determine who is going to be the provider of the genetic material of the baby, of the sperm, who's going to be providing it first, especially if we have couples. I've had many couples where they decided to use a sperm from both of them. Basically, half of the eggs from the donor were fertilized by partner A, and the second half was fertilized by partner B, and they decided to transfer one embryo at a time from each batch, basically, so both of them would contribute to a pregnancy. So individual usually providing sperm has to undergo some testing. The main test that we start with is semen analysis, which gives us an idea in terms of how the sperm quality is. We look at several parameters in semen analysis. The volume of the sample is important, but most importantly, the number of sperm, the concentration or the number of sperm, motility, are they moving well or no, and the morphology or the shape of sperm. It has to have single head, single tail, good shape head and good shape tail. In addition, of course, the intended parent will undergo some testing, mainly blood tests to make sure there's no infections. In addition, one important test is a carrier genetic screening, which tests for several mutations. Anyone us could carry. But the main idea here is to make sure that when you select an egg donor, that the egg donor doesn't carry the same exact mutation that you carry, to prevent transmission of any disease to your children. Of course, a physical exam will also be done to ensure that everything is going well. Now, in terms of the egg donor, selection of an egg donor is a very important step here. In most cases, it is anonymous egg donation. Egg donors are also screened very well before being available for donation. They have to pass several screening. Most importantly, they have to have no infections. All the infectious disease testing have to be done and be negative. They have to have good ovarian reserve. And of course, their age is very, very important. They have to be young because the quality of the eggs correlate with women's age. So they have to be young, have good number of eggs to provide the highest success rate possible to the intended parents. We have several donors at the Advanced Fertility Center of Chicago. We screen them very well, and we've been using egg donation for so many years, and we are having very high success rate using egg donation for same-sex couple or straight couples. And of course, they also do carrier genetic screening to ensure that we know what mutation they are carrying, to ensure that the couples don't carry the same mutation. Of course, the selection process entails seeing some pictures of the donors, adulthood or childhood pictures. Detailed questionnaires will be filled by the donor, including physical characteristics, education, obstetrical history, do they have children or no? Of course, we always do a psychological evaluation, and the note from the psychologist will be always included in the report of each donor. And the third part is the uterus or a gestational carrier. And it would be great for Staci or Roxanne to tell us about surrogacy and selection process and how does it go?
Yeah, definitely. We'll start out a little bit with the criteria that we are looking for when we're accepting surrogates into our program. This may vary a little bit between agencies or even between, fertility centers, but we certainly have our, our black and white criteria that is a must within our program. So what we're looking for within a surrogate is, of course, the age. The ages of the surrogates within our program have to be between 21 to 43. So that's important. We're also looking at number of C-sections. So we will not accept a surrogate who has had more than 3 C-section deliveries. Again, this may range a little bit between fertility centers, of course. Just while we're on that topic, what do you feel about the maximum number of C-sections?
Yeah, well, I agree. I mean, 3 C-section is good enough because, you are putting the surrogate at high risk of complications for her, as well as also the baby too. So if you have issues with hemorrhage for the pregnant woman, it's really, because here we're not only taking care of the baby, we have to take care of everyone involved, the donor, egg donor, and the pregnant woman, the surrogate, and the baby. So it's very important to take care of everyone.
Right, absolutely. And a few more of those criteria would be location. Of course, they have to live in legally friendly states. The majority of the states nowadays are friendly. There are a few now that are not. One of those, for example, is Michigan. We will not accept a surrogate in the state of Michigan. They also have to have financial stability. They cannot be in any type of government or state assistance. That's really important. Exactly. And also full support. They have to have a support network. So if they have a partner, they have to have that support of that partner to become, a surrogate with our program. We've been approached many times over the past 14 years of surrogates who tell us they're so excited to be a surrogate, but yet their partner's just not quite there yet. And maybe they can coax them into being supportive. And we just tell them, no, it's just not a good time. You really Exactly. Have to have that support. If you don't have a partner, whether it's your family, friends, whoever it may be, it's important that they have that full support network. And then obviously no drinking, no smoking. Those are obviously the obvious criteria. So definitely in terms of the surrogates who we accept into our program, it's right around probably under 10% of the women who actually apply. we are being contacted every day by potential surrogates, but because of those criterias that we're looking at, we really only accept maybe a little under 10%. So thankfully we are contacted quite often. So it does, help us be able to obviously match intended parents within a respectful time frame, just because the volume of surrogates who do come through our doors. But again, we have to be very cautious in the surrogates that we can accept, for sure.
Absolutely. I mean, it's very important, as you said. These criteria are very important because you want to provide the best service to your patients. The same for us when we select egg donors. Approximately 10% of donors that would submit applications, very small proportion of them will be accepted, because you really need to have a reliable person who have good criteria to give your patients very high success rate. So I certainly agree and support your decision.
Absolutely. And of course, with the surrogates, they have to have had at least one pregnancy and be raising that child to become a surrogate. So that's really important as well. So that's an automatic disqualifier if they've never had any children of their own, of course.
Yes. I mean, I agree with the support too, because I mean, it's
So
a decision.
important.
If the partner is not agreeing now, it's not only a month or two that you can change your mind. It's going to be 9 months at least to deliver.
Right.
And you have to be contacted by the agency to make sure everything is fine. The intended parents are worried. They want to make sure the baby is fine. So it's not something that you can change your mind in a month or 2 or 3. If you back up, you can't really back up at that point.
Right, absolutely. It's an overwhelming obligation as well as responsibility. So, once they commit to becoming a surrogate, it's, you have to be prepared for, what if the first embryo transfer is not successful?
Exactly.
You have to be prepared for, there could be some bumps in the road. So it's really a long-term commitment, like you said.
Absolutely.
So it's really important. And obviously the surrogates, they do complete the psychological screening. That's part of our intake process. Mm-hmm. Before we even start sharing profiles amongst the intended parents and the surrogates, we want to make sure that the surrogate and her partner as well, have completed the psychological evaluation. So that's really important as well. So it's a very structured process, as you know. So it does leave very little room for any type of error, I feel, as long as you're working with a great team, that's important.
Exactly. And I know that you have a great team that we're working with, for sure.
Thank you. Yes, I'm very proud of our team. And likewise, you guys are amazing as well. So we receive a lot of positive feedback from surrogates who are pregnant through your program. So yeah, they
thank you. Appreciate it. How was your experience, Roxanne, in terms of surrogate?
My experience was amazing. My surrogate just turned 3 recently, the end of May. My surrogate baby. I still have a great relationship with the intended, or the fathers now. So they just called me the other day and we talked, and learning their language. So hopefully I can speak a little bit better to the little girl. But yeah, for me it was amazing.
How did you decide to be a surrogate?
So between my husband and I, we're a blended family. We have 7 children of our own. And after our youngest was born, we knew that our family was complete, but we were open to the wanting to be able to give a family, to a couple that was looking to have children, because we were so blessed, and we had so much fun with this huge big family. That is kind of where it had come from. And I loved being pregnant, and my husband was so supportive of the pregnancy, and with a same-sex couple, he was, like I said, it's personal for us. So it was no question to
Roxanne,
go forward.
Did you have a preference when you were reviewing profiles of a same-sex couple, or maybe a heterosexual couple, or a single intended parent? Did you have any preference, and what made you decide to choose the intended fathers, or the fathers, now that you did?
Yeah, no, I was open. I went into it just kind of open and loving, and I didn't really have anyone that I wouldn't work with, which I think is kind of easier. I think going into this process, you're coming from your heart. You're is the best place to come from. And then when I was shown their profile, it was like, you want to say, like, love at first sight. You just feel that connection with the profile and the pictures. Yeah. And so, yeah, and it just went from there. But I was like, I think I put on my profile, like communication, I wanted it to be like an organic thing. You know, I wasn't like, I want to check in, you know, once a week or once a month, you know, like I was open to, if they wanted to have communication, I was more than happy to have communication. But if they didn't, then that would have been something I had to accept as well.
Yeah, and I think that's really important too in terms of the matching process between intended parents and their surrogate. So of course you have, you know, just the checklist if you're transferring 1 or 2 embryos, you know, termination stance, but relationship is really important as well. So we want to make sure that the intended parents are comfortable with the amount of communication and vice versa that the surrogate is looking for. So that's just, it's really important because it's our goal, of course, obviously to have a successful journey, but we want everybody to be comfortable and be happy and enjoy it. You know, it's a stressful process anyways. So, you know, if we can make sure that that match between the intended parents and the surrogate is really aligned properly, it just makes it that much better. Yeah.
Absolutely. How long do you think usually when intended parents are coming to find a surrogate, how long does it take usually? Does it differ between markets, between states where you are?
Yeah, good question. On average, the waiting time from the time that intended parents were to sign up with our agency until they're matched, it's generally right around 10 weeks or so, 8 to 10 weeks. It's fairly quick. Yeah, we put you know, a lot of emphasis definitely on the surrogates marketing. That's really almost 100% of the marketing that we do is finding those surrogates, because we certainly understand, you know, that the intended parents, they want to move forward with their journey and they want to get matched as quickly as possible. So, and some intended parents may have a few more criteria than others. So for example, they may only want to work with a surrogate from a particular state. And then some intended parents are open to any state. So that, of course, you may have some limitations there. But on average, it's usually between 8 to 10 weeks from the time that they sign up until they're matched.
Perfect. I mean, this is a great number for sure compared to many other agencies. As far as I know some patients would wait 6 months, sometimes 1 year to find a surrogate.
Yeah, 6 months is usually, that would be definitely more of a max amount of time. And again, a lot of it really does boil down to the intended parents' overall criteria.
Exactly.
You know, we've also added another question into the criteria when we are matching, and that is the COVID vaccination. Are intended parents wanting their surrogate to have that or be open to getting that prior to the embryo transfer? So yeah. So we're seeing, you know, a little bit of different opinions there, but for the most part, it hasn't really, you know, increased the waiting time.
Perfect. And how many states do you have a surrogate in?
Oh goodness, all throughout the United States. We do avoid a few. Yeah, Nebraska, we do not work with surrogates from, Louisiana or Michigan. But realistically, throughout the United States, you know, it's the most common definitely is in the Midwest here. We're headquartered in Chicago, so we've been here for 14 years. So just naturally, we have many surrogates here. Texas, Florida is a pretty popular location for us as well. We do have satellite offices in those locations. And then out on the East Coast, we're seeing that definitely kind of being a runner-up in terms of, the surrogates who are working with our program, for sure.
Yeah, it was recently approved in New York, which is great for patients.
Yeah, New York now since April. So that's a great, that's awesome for surrogacy, especially for the same sex intended parents, because we have so many intended parents come to us from the East Coast, particularly New York, who have, you know, weren't able to utilize a surrogate in the state of New York. So now that's opened up, and that's been really helpful too. Absolutely. Yeah, for sure. You know, one of the common questions that we receive quite often from the same-sex couples is it going to be harder to match them? Are surrogates open to caring for them? And if so, what about their family? Are they supportive? And, you know, we haven't seen really much difference between a same-sex couple, you know, wait time versus a heterosexual couple. In fact, we have some surrogates who prefer to carry for a same-sex couple. So yeah, that's something I think is important for them, you know, to know, because I know, you know, obviously going through surrogacy as a gay man or, you know, gay couple, you know, there's the disadvantages, right? I do feel it's becoming a lot easier nowadays. I think fertility centers are really forming more of a positive, it's very common now, you know, as far as the like surrogacy and egg donation. So I think that's been really, really helpful over the years, and it's pretty awesome. So we want everybody to feel comfortable.
Yeah, I'm sure it's getting way better now compared to 5 and 10 years ago.
Yes.
In every aspect, including fertility for sure.
Yeah, even like the legal process, now that they've, legalized the same-sex marriage, I think that's just been amazing for, just the parentage once the babies are born, that they're both recognized as the legal parents in many of the states. So I think that's just amazing. So I'm happy to see that,
Yes.
for sure. Yeah.
Now, what about the legal aspects? How do you counsel them about the legal aspect of parenthood?
Yeah, we answer their general questions. It's state by state here in the United States. So all states are a little differently, the way that the parentage is processed, whether it's a pre-birth order, post-birth order, if there's any type of, courts documentation that needs to be completed, after the baby is born. But we always will recommend and refer to an attorney. We work with some amazing attorneys here in the United States. And the attorneys are wonderful. Communication, they'll be able to answer their questions. But yeah, definitely, we involve the attorneys. We feel that, it's best that they communicate with the experts, and we put them in touch, and everything it's really smooth sailing, and it works out really well.
Perfect. Yeah. So we're going to move on now to lesbian couples and individuals, which we see very, very frequently too. Now, usually when they come here, we would like to know who's going to be providing the eggs, who's going to be carrying the pregnancy. Of course, if in these cases, usually if one partner is going to be the only one who's involved in carrying the pregnancy or providing the eggs, then IUI could be a simple treatment, or IVF if needed. If partner A and partner B are going to be participating in the pregnancy, usually if partner A is going to be providing the eggs and partner B is going to be carrying the pregnancy, which is becoming very popular these days, this is when we do something called reciprocal IVF, where we take eggs from partner A, fertilize them with sperm donor, make embryos, put the best embryo in partner B, and let partner carry the pregnancy. Assuming that partner A is the one who's going to be providing eggs and carrying the pregnancy, as I said, usually IUI is, the first line treatment because it's a simple treatment. They don't really have infertility, so most of the time success rate is very high. And IUI means intrauterine insemination, in which we time it exactly on the day of ovulation, where we wash the sperm on that day, and then inseminate it inside the uterine cavity. Now,
what do you see more of with the sperm source? Obviously, you work with many more lesbians than we would, obviously. But in terms of, do you see more of them utilizing a sperm bank, or do they have, I know there's friends that sometimes will be happy to help them. So what do you see more of?
Very good question. So the overwhelming majority use anonymous sperm donors from sperm bank. Overwhelming majority. I've had few patients who wanted to use directed donor. The only problem with that is that they have to be quarantined for 6 months. And most of the time, every couple come here, they want to get pregnant today. They don't want to wait 6 months. And that's how it goes. They want to do the testing, and then with the next period, they want to start treatment. And most of the time when they know about the quarantine and the regulation, which we have to follow to protect the patient and the pregnancy. And so most of the time, it's not the case. I've had several patients who used, but overwhelming majority, they used anonymous donor. And so, IUI is very common in these cases. Of course, if a woman is older than 37, or especially after 39, 40, starting with IVF is not a bad option. It's actually a good option because IUI success rate is relatively low in general. In addition, of course, if a woman has blocked tubes or other infertility issues, IVF could be the best option instead of IUI. Now, as you mentioned, now how to select sperm is also very important. It's similar to egg donor selection, but a little bit easier because we have many sperm banks, and they have usually many sperm donors. And then these donors are always screened for sexually transmitted infections before they even being listed in these banks. And so they all have good semen analysis too. They all had negative infectious disease testing, and they have genetic screening testing available too. So the intended parent can select a sperm donor who doesn't carry the exact same mutation that they do carry. We also, in these cases, because of the cytomegalovirus, it could affect pregnancy, we always test intended parent for cytomegalovirus immunity. So if the intended parent is immune to CMV, then they could select CMV negative or CMV positive sperm donor. If the intended parent is not immune, then we would recommend selecting the CMV negative sperm donor. So these are the two main criteria. Genetics are the two most important criteria for sperm selection, other than, of course, physical characteristics, race, ethnicity, education, any other characteristics that they would like to choose for sure. And a common question that we get asked is how the IUI is done. Should we give them medication to stimulate the ovaries to ovulate, or should we do it naturally? And then, so usually if someone has infertility and they are not conceiving, then yes, giving them medication would help them release maybe 2 or 3 eggs to increase their chances of conceiving. However, in most cases where, lesbian couples, they don't really have infertility. And in many cases, they do have regular cycles. And so giving them medication doesn't really help them as much as it increases the risk of multiple gestations, which is why we always prefer to do natural IUI, where we just monitor the cycle and let them know when they're going to ovulate and do the IUI on that day. That will minimize the risk of having multiple gestations, which is associated with high risk of complications in pregnancy. Now, having said that, doesn't mean we cannot use medication. Of course, if someone has ovulatory dysfunction, that means they don't have regular cycles or they don't ovulate normally, then they would benefit from medications. Or if someone have undergone multiple natural cycles and didn't get pregnant, then adding medications to improve their success rate is reasonable too. Of course, if IUI is not successful for many different reasons, then IVF would be a good option as a backup.
That was my next question. How often do you see your patients going from an IUI to IVF with using a sperm donor?
Yeah, it's a very important question, because many patients, most of the patients who don't have infertility issues and are young, most of the time they get pregnant with simple IUI. Now, many patients though, they just want to have the highest success rate possible, or they wanna, again, the reciprocal IVF is becoming very common. That's the only way so far to let both of them get involved in a single pregnancy. In addition, it also helps them create some embryos that they can transfer in the future in case the other partner, not necessarily now, but the other partner might be willing to carry one of the embryos in a year or two, which is why they decide sometimes just to do IVF right away, get embryos, transfer one now, and then keep the other embryos frozen for future use.
Right. So do you see many of the patients choosing IVF directly due to maybe wanting to genetically test the embryos, or maybe gender selection or what have you?
Exactly. That's overall it is possible sometimes, especially if they already have children and they have certain sex and they want to do a gender selection for the next baby. But I found also interestingly, gay couples mainly, most of the time they want to do genetic testing. First of all, because they're using surrogate and they want to maximize the success rate, because they don't want to involve the surrogate in multiple cycles, and they want to maximize the success rate without the need of putting more than one embryo. So it's the safest, highest success rate possible. In addition, some of them would prefer certain gender, because if they are gay, sometimes they tell me, I don't want to have a girl, I just want to have a boy. It's the opposite. Sometimes it's the opposite.
Yeah, we see definitely more males transfer than females when given a choice.
Exactly. So many times they prefer to do that, of course, if it is possible. But many of them would say, if I have both gender, I would select a male. But if I have a girl, I don't mind transferring it,
right?
Which is great, So it certainly give them that option. Genetic testing is becoming more and more common. We explain usually the risk and benefit of genetic testing, and some patients prefer to use it, some patients don't, especially if they have history of miscarriages or older ages. They would benefit more than younger couples for sure.
Right, right. And then in regards to the surrogacy aspect, are you comfortable with transferring to embryos? I've seen definitely a reduction in transferring to. Back in the day, we've seen so many double embryo transfers, but nowadays we're seeing many more single embryo transfers. So what is your outlook on that with obviously gay couples? Because many times they want to create those embryos with utilizing both of their genetics with the same donor and transferring one of each. So how do you feel about that?
Exactly. So most of the time you will be able to convince them that it is high risk for the gestational carrier and their babies to have two. Because of genetic testing now, they would select a good embryo that would give them, at least 65 and not 70% chance of having a baby with a single embryo. And so they are most of the time satisfied with this high success rate. And when they know that the embryos that are frozen would still give them the same exact success rate if they come back in a year or two, they are convinced. Having said that, in rare occasions, some people come here, they don't change their
They're
mind.
adamant, yeah.
You do, no matter what you tell them. So then we would let them do that if they really insist of doing that. And unfortunately, most of the time, when you put two, most of the time you're gonna have twins. Because again, the embryos are good and
Well, especially with the gay men when they're starting out with utilizing an egg donor, and then you move forward to the genetic testing, and then you're having the best of the best outcome for high success. So
exactly, I'm sure you see that the same request frequently, right?
Yes, and we have the same really advice that we definitely recommend transferring one, but sometimes the intended fathers are really adamant they want to transfer two and hopefully have twins. And as long as the fertility center is comfortable with that, after of course educating them, then that's the route they go. And I always tell them it's always the ultimate goal is having a full-term healthy pregnancy, a nice chubby baby at the end, rather than to preemies in a NICU for could be several months. So but yeah, for sure, we do see that quite a bit. Not as much as we used to, but we are seeing more, like you said, intended fathers that are comfortable with knowing that if they want to have, children down the road, they have their embryos, they can do that. We're also seeing a lot of intended parents working with two surrogates at the same time, and that's become more common. So just to reduce that overall high risk.
Exactly. So it used to be like, because I always explain to them, because sometimes they want to get it done fast, but sometimes they want to save also some cost. They want to increase their chances and decrease, instead of doing it twice. But I tell them also that if you deliver early, the baby's going to be in the ICU, and then you're going to have way more costs in doing so.
Expenses,
places, in addition to the health of the baby. That's really the most important factor too.
For sure. And we always, of course, educate intended parents that in terms of even trying to save costs for when and where you can, as far as our agency fees, we do reduce those as well. So if it's a couple that's working with us for more than one surrogacy journey, they'll receive a discount on our agency fees. So we certainly try to help with that as well.
Yeah, that's really nice to encourage them in a way, in a financial way to do
it's an expensive process. So any way that we can help, we certainly are happy to do that.
Perfect. So just a quick background over, IVF, because as we spoke about, IVF for gay couples or IVF for reciprocal IVF, how IVF is done. It's a process in which you start by evaluating the woman who's undergoing stimulation. We will do usually initial evaluation to test the ovarian reserve to determine the best stimulation protocol for that patient. Then usually women undergo stimulation for approximately 9 to 12 days, during which women would be monitored very frequently, every day or every other day sometimes, to ensure that she is responding well. We don't want them to over-respond and be sick and have hyperstimulation, but we also don't want them to have only 3 or 4 eggs and have lower success rate, which is why we monitor them very closely to ensure that they're responding well. 2 weeks after these medication, 10 days or 9 days or 12 days, we give them trigger shot, and then we retrieve the eggs. It's a simple procedure. It takes only 10 minutes. Women would be, sedated for 10 minutes. Egg retrieval is done usually vaginally under ultrasound guidance. After the patient wakes up from the sedation, we'll let them know how many eggs they have. And then the following day, we'll give them updates of how many embryos they have, how many fertilized eggs, how many embryos. And then a few days later, we will let them know how many embryos made it to that stage where we can either transfer if someone is doing transfer, or how many embryos were frozen or genetically tested and frozen. And then again, in most cases, especially in egg donation cases or lesbian women who don't have fertility, in most cases, they will have extra embryos frozen. And not all cases, but the majority of them would have. And these embryos will be frozen and can be used in a year or 2 or 5 or 10 or 15. They would still have the same success rate in the future. The survival rate of these embryos is very high. In our lab is approximately 97 to 98%, which is a pretty good survival rate overall. And so, the technology is helping us to provide high success rate in a safe way to decrease the risk of having multiple gestations for sure.
What do you see a difference in overall success rate between a fresh embryo transfer versus a frozen?
In general, if the embryo is not genetically tested, if the hormones are good during the cycle and the lining is good, they would have similar success rate. There's always 15 to 20% of women that would not be ideal for fresh transfer. When we are stimulating them, if we see that the hormones are not ideal, the environment is not good, we would recommend freeze all, whether the embryos, even if they have too many embryos, even if they were planning to do fresh transfer, we tell them that the success rate of frozen is going to be higher, let's freeze these embryos. So we individualize care to patients to see which one are the 80% or so and which one are the 20%. But if you don't do the genetic testing, they would have the same success rate if you select the patient well and you know which one are a good candidate for fresh transfer.
Right. And I know definitely with the surrogates, and Roxanne, you probably see this all the time being a case manager. The majority of the surrogates, and probably all of them really, they certainly respect and prefer that the intended parents already have embryos frozen. Once they're matched with the intended parents, because if they don't have their embryos yet, anything could really possibly happen, right? It could delay the entire IVF cycle. So it is definitely peace of mind for the surrogates when the intended parents already have those embryos created. For sure. Don't you see that as well, Roxy? I'm sure.
Yeah, I definitely see that. And that's why sometimes we encourage parents that are doing their embryo creation, but haven't decided on surrogacy, like, we can do those together while you are creating your embryos. We can be looking, searching for the best candidate for you to lessen the time, because like you'd said, they want to come in and be pregnant yesterday. So we can try and get that going all at the same time while their embryos are being created, so that if the process is going smoothly with their creation, by the time the embryos are ready, we have the surrogate and she's almost ready for transfer.
It's out really, really well, for sure. Yeah.
That's a very efficient way to save them time. You plan the egg donation, which is very straightforward for us to do. The egg donation process is straightforward. At the same time, they would be looking to match with a surrogate.
Right, that's fast usually. Yeah, it works out really well. And like Roxy said, sometimes the intended parents come to us and for example, they've already created their embryos, which is great, but then they wanted to be matched yesterday with the surrogate. Mm-hmm. So it's always, yes, when they know that this is the route, obviously with a same-sex couple, generally they'll start the surrogacy search as well, at the same time start creating their embryos, find their donor, secure their donor, and start the process. And then it works really well, because by the time they have their embryos, they should be matched with a surrogate, or really close to being matched with a surrogate. And we can, at that point, focus on the surrogacy aspect, and it works out really nice.
Yeah, in most cases, it works very well when you work simultaneously, because it's almost always the egg donation is fast. And so you will be done almost by the time you are selecting and confirming that the surrogate is ready.
Right.
In many cases, we're finding now that also couples or individuals, they create embryos now. They are not, necessarily ready to have a baby now. Right. But they want to create embryos. They want to just, not think about it anymore. And then in a year or two, they want to start focusing on looking for a surrogate. So we see that frequently now, for sure.
Yeah, same. We do as well. We'll have many intended parents find a donor that they really like and they just want to secure that donor, but they're not quite yet ready. Maybe it's financial reasons or whatever the reasons may be to start with the surrogacy end. So they'll secure that donor and then move forward with creating the embryos. And then they have those ready to go when it is the right time for them to move forward with the surrogate. So yeah, it works out really well. Yeah. And that is usually a common question. Well, is it going to reduce the overall success because embryos are frozen? And of course, we tell them absolutely not. The success rates are still very high. So
exactly, that helped us a lot. When the freezing technique has become much better, especially with the vitrification or fast freezing.
So quick, right?
Yeah, that significantly improved the survival rate to 97-98%, decreased, it's almost the same success rate if the embryo is good. And, in some literature describe frozen transfer might be even a little bit better. Again, if you don't select the patients, but in general, the embryo is not really harmed from freezing in most cases, in overwhelming majority of cases. We have babies from frozen transfer almost every day for sure.
Yeah, right. It's amazing the technology that we have these days, right? And it's always just when we think it's so amazing, it just gets better.
Exactly. This is why this field is so interesting and fascinating. It
really is fascinating. It really is. And I did want to, before we complete our webinar, I always like to point out with the surrogates just how amazing they are of people to literally make this decision to help another couple or individual, build their family and especially for the same-sex couples, when they obviously this is their only route to obviously having children. If they want a genetic child, obviously there's adoption, that's amazing as well. But there's just something, with the surrogates that it's just, they have to have, like Roxanne said, a heart of gold. And it doesn't just impact, the surrogate and the intended father's relationship, but it's their entire family. You have grandparents and aunts and uncles, and it's just an extension of life that will continue to carry on. And I think that's just, it's pretty remarkable. For sure.
Absolutely. I really appreciate this surrogate. I mean, they are doing an amazing job. Again, egg donors are extremely important too for us.
Absolutely.
Absolutely. They still also, come in monitoring, stimulation, take all these needles, do a retrieval procedure. So it's not easy for them too. The surrogate also get pregnant for 9 months. So, I mean, they come.
It's a teamwork effort.
It's a major process for sure.
It really is. And yeah, for sure with the egg donors as well. I know that, like you said, they're taking a lot of those injections and a lot of screening, especially once they start the stimulations. And sometimes they don't know when their next appointment is until their labs come back. And so it's just such an overwhelming responsibility. So yeah, definitely it's amazing that we have the donors and the surrogates and the intended parents, and we put it all together. So
exactly. They're almost always happy at the end because they know what they're doing. It's really going to change the life of many, many people for sure.
Absolutely. Yeah, absolutely.
Especially from a donor, sometimes they donate like 20 eggs, for example, which we can split into 2 or 3 lots and help multiple couples at the same time, which is a great opportunity to help people as much as you can.
Yeah, that was going to be a question too with the donor. I know we were speaking on the donors a little bit ago. Do you offer shared cycles with egg donors?
We offer the frozen cycles in our lab is almost the same as shared. So what we do is that we have frozen eggs, like 5, 6, or 7 eggs, and so we make it almost like shared with the frozen egg donation process, because the fresh egg donation you usually get between 10 and 20 at least eggs, which will give you a very high success rate. On average at least 70%. If you do frozen egg donation, you get lower number of eggs because that donor split it between two recipients usually. And then so each one of them will pay almost half price, and they will still have decent success rate, at least 50% with 1 embryo, and approximately 70 with 2. And so they might have 1 or 2 extra embryo frozen, they might not, but 50% is very good success rate for many patients.
Right, absolutely. And what do you see in terms of utilizing fresh eggs versus frozen eggs in terms of overall success?
Yeah, so the success rate is the same because the egg quality is almost the same. The survival rate of eggs that are frozen is 80 to 90%, so it's pretty decent for sure. But usually the success rate of frozen egg donation is slightly lower in our lab because it's a shared again, because you're only selecting 5 or 6 or 7. So even if you take 5 or 6 or 7 eggs from a fresh egg donor, most likely you're going to have between 50 and 60 instead of 70, because you don't have too many to select from, not because you diminish the quality of the eggs. But that also, the fresh egg donation is associated with higher costs to the patient. And so some patient would say, well, I only want to have 1 baby. I don't really need to have 5 or 6 embryos frozen. And, this is half cost of what it is. So I'm going to use frozen egg donation, as opposed to couples who come here and say, you know what, we would like to have at least 2 or 3 children. And we would like to have the highest success rate possible. And so instead of having a selection of egg donation now, and then a year or 2 selection of another egg donation, an egg donor, then we'll do it once. So they will be all from the same donor. And when they come back, they will have frozen embryos to transfer.
Right. Yeah. And I think in general too, especially with the same sex couple, they prefer the fresh. That way they can, especially if they're utilizing both of their genetics. Yeah. That's obviously the best route to go.
Yes. For gay couples, almost always they use fresh, because they want to also do genetic testing in most cases because of surrogacy. And then with frozen eggs, you're starting from 5 eggs. You certainly don't want to have 1 or 2 embryos only to be tested at the end. But with fresh eggs, in most cases, you'll have several embryos tested, and there's a much higher chance of having normal embryos of both genders. And so that would help them also in this option for sure.
Great. Yeah, that's super helpful.
Yes. And so the last topic here is a transgender. We don't want to forget them, but it's the same process. The main difference is that if the transgender has ovaries and they want to donate eggs, they can certainly do that. They can, most of the time, they could stop testosterone supplementation a few weeks before. We don't have clear guidelines of when they should stop the testosterone, but usually a few weeks before stimulation has been working very well as far as we know. And then they can do egg donation, and then their partner could be the recipient sometimes. Now, if the intended parent has a uterus and would like to carry, also, if they have a uterus, if they stop the hormones, they could also carry the pregnancy if they wish to carry, which is great. That's a great option for gender couples too.
Right, absolutely. Yeah, like I was saying, the technology is just so amazing now. So yeah, so many different options that are successful.
Everyone can have a baby these days, yes.
Everybody can have a baby. It's like Oprah, everybody can have a car, so everybody can have a baby.
Exactly. So let's see if we have any questions here. I think we addressed most of these topic questions in terms of, we already covered this topic too. Okay.
It doesn't look like we have any chat questions at this time. If you have any, feel free to send those through in the chat and we'd be happy to answer any.
We did have prior to this, so it wasn't on the chat, but it was emailed to us. It was a question from an intended father, single intended father. I mean, it was more for Roxy about the relationship with your husband with the intended fathers or intended father. Was how involved, basically, that was the question. How involved was your husband during that?
Oh, yeah. Well, my husband was involved kind of from the beginning with the agency and the match meeting. He met the intended fathers with me at the same time, just so, you can get a feeling for each other and the support that he would be giving me. So yeah, I would say that my husband and my intended fathers actually have a great relationship. When we did finally meet in person, they exchanged numbers, and I know they have side conversations for holidays and birthdays without me, even though, like I'm the main communicator, but I know they have their own communication outside of me. So definitely for us in our situation, we have become an extended family. So yeah, I would just say that my husband was involved from, the moment I said, hey, so I'm like, we're really thinking about this, right? Like this is something that we're in for. And my husband was like all in 100%, he was ready for it. So, and he was open to any family as well. So we just went into it.
What did you find the most challenging part of the surrogacy?
Oh my goodness, maybe like emotions, bumps in the road when everything doesn't go as planned when transfers fail, and you just feel like, what did I do wrong? What didn't I do right? Because it is your emotion and it's your heart, and you feel like you let people down, but we know it's just science, and, our bodies can only do what they can do, right?
Exactly.
But yeah, I think some of the emotion is
And how was
hard.
your feeling when you had the first pregnancy ultrasound?
Oh my gosh, it was so amazing, right?
Almost the same when you were pregnant?
Yeah, because you're
Okay.
thinking, we're here, we've made it to this point, especially if you've had failed transfers, like when you get to that point, even the first beta, it's like, it's almost like
Yeah,
you
you
don't
had
want
a
to breathe.
couple. You had a couple failed transfers,
I did
right?
have a couple failed transfers, yeah. So that was definitely the hardest part, were those bumps in the road when it doesn't go perfect,
Exactly.
and you have to work with your parents, or your intended parents, and your family that's seeing you, supporting you through the the tears as well.
Yeah, and again, I think that's why, again, it's just so important that all surrogates understand that that's part of the requirements. You have to have that support, and you have to be emotionally prepared for the process. Is obviously the intended parents as well. They, you have to put this trust into the surrogate, and at that point, it's a stranger. So it's, but overall, it's remarkable, and I feel we do an amazing job matching intended parents with their surrogates, and it really does come down to teamwork and just open communication, for sure.
Open and
Exactly.
honest communication, even having those rough, uncomfortable conversations, in the match meeting or in legal. I think going into this process for the surrogate and the intended parents, you just have to be honest on what your expectations are, and how they will be met, and what will happen if they're not met. Because down the line, if you're 6 months pregnant and something's not going right, then you're frustrated, and you guys haven't talked about it, or you don't feel like you have that communication.
Yeah, very important.
Yeah, exactly. I mean, setting up the expectation is very important in any treatment, not only with surrogacy, for sure, because patients see always happy endings outside, online, patients sharing pictures. We did IVF, we had a baby. Well, most of the time, these IVF are not the first cycle that they did. Many times they did IUI before, they did treatment before. And so I always remind patients, hey, it's great. You're going to go and share your news, but it's not always successful from the first time. We had many successful stories from the first cycle, for sure. Even in the older age group, sometimes with IUI, they get pregnant, they have a baby. But that's not always the case. Many times you need to do it multiple times to have the final outcome, which is almost always worth it, Nothing easy in life. That's very important. So you have to fight for it.
Right. Especially when there's not an explanation. You can have great quality embryos and a great lining, and it's not successful. And sometimes that's just the way it is. But the good thing is that overall, it's a very successful process. And like you said, hopefully they'll have frozen embryos and just jump right back in and get started again. And so I think it's important, again, it comes down to support.
Absolutely. It's always setting up the expectations. Support group is very important. And, again, as you said, technology has been improving a lot. So the success rate now is way higher than, 10 years ago.
Remarkable.
And the genetic technology, biopsy, and genetic testing is also improving. So we still don't have explanation, but we are having some explanation of why 10 years ago, some of them were not succeeding. We still have a lot to do, for sure, which makes us feel very interesting and keep moving.
Yeah.
And so what's next, how we can improve success rate. We are now at 60 or 70, we want to make it 80, we want to make it more. Let's see how we can improve it. It's unexplained now, most likely might be unexplained in 5-10 years from now. So which makes this field extremely fascinating. Every day we're learning something, which is great.
Yes, every day is a new day. It's exciting every day, never dull.
Thank you so much for being with us, Staci,
Yeah,
Roxanne,
thank you.
CJ. It was great webinar. If you guys have any questions for any of us, feel free to reach out anytime. How would they be able to reach you guys if they want to have a surrogate?
Certainly, yes. They can call our office, of course, or they can just reach out through email. All that information is on our website, FamilySourceConsultants.com, and we will get back to anybody immediately, and we can certainly get the information they need to get started.
Perfect. Yes. The customer service is great with you guys, which is very, very important for this stressful event for the couples for sure.
Yeah, it is. That's something we really pride ourselves in, is the communication. Yeah, that's important, as you know.
Yes, exactly. And if you guys want, to reach us, advancedfertility.com, you can always call 847-662-1818, or you can send us emails through the emails that you guys received. Wish you good evening. Good night. Take
Thanks,
care, guys.
everybody.
Thanks for joining,
Bye-bye.
everybody. Happy Pride Month.
Yeah, happy Pride Month. Bye-bye.
Bye.